Welcome to this lecture for abnormal psychology. I'll be talking about the second half of the chapter on anxiety disorders. Okay, so what we'll cover are the trauma and stress related disorders, including PTSD and acute stress disorder. Cover those most in depth, and then pretty quickly run over the attachment disorders, reactive attachment disorder, and disinhibited social engagement disorder, as well as touching briefly on the adjustment disorders. We'll also talk about the obsessive-compulsive and related disorders, OCD and body dysmorphic disorder, and then pretty briefly going over hoarding disorder, trichotillomania, and excoriation. Okay, PTSD, DSM-V, diagnostic criteria. And just a quick note before I get too far on here. These criteria I'll talk about are for adults and kids over 6. The criteria for little kids, kids under 6, are slightly different to reflect developmental differences in their ability to express themselves. But I won't go over all those differences here. Just know that it's a little different for little ones when they unfortunately experience trauma. Okay, so for PTSD, you have to be exposed to a traumatic event, right? And that's now defined as death, serious injury, or sexual violence via one of the following. Direct experience, so you're the one being victimized, being hurt, in danger of dying. Witnessing it in person, the person, seeing somebody, this trauma happen to somebody else is traumatic for you. Learning that a trauma occurred to someone close to you. And this has to be, so if this is death, like learning of the death of a loved one, if your 97-year-old grandmother dies, that wouldn't qualify for the DSM as a traumatic event. For death, it needs to be violent or unexpected. But again, something traumatic happens to someone very close to you can be psychologically traumatic for yourself. And then repeated or extreme exposure to aversive details of traumatic events. And that bit's in there really for those people that are getting that secondary traumatization. First responders, physicians, medics on the battlefield who, they may not be there when the bombs are going off, but they're seeing the aftermath and hearing the stories over and over and over again, kind of this chronic trauma rather than one single event. Okay, so there's some trauma that's going to affect a person. And then after the trauma, they have the development of this pattern of symptoms, including one or more of the following intrusion symptoms, right? So this means intrusive memories about the traumatic event. So you don't want to think about it, but the thought comes in your head, and you're not. For an intrusive memory, it's just that. Oh yeah, oh God, I'm thinking about that. You're not there. You're just thinking about it. Dreams about the event, nightmares. Usually they're negative dreams. Dissociative reactions or flashbacks. So this is where people, again, more than just a memory. Oh yeah, I remember what it was like. They actually experience as if they were there. Either internally, they kind of go in their mind as if they're there, or they may even act out as if they're there. Suddenly think that people are attacking them and start fighting. Psychological distress in reaction to trauma cues, and those trauma cues can be external or internal. So let's say if we're talking about combat-related trauma. An external cue might be the smell of one that I hadn't heard before, transmission fluid. Somebody who worked in a motor pool that came under fire, that particular smell was associated with that moment, and so that was a cue for them. An internal cue could be your own, like an increase in heart rate, right? Where during the traumatic event, if you had increase in heart rate, dry mouth, all those typical kind of fear reaction stuff, those internal cues can become associated with the traumatic event itself. But then again, whenever you have those exposed to those cues in some form or fashion, you have psychological distress, fear, anxiety, or it could be physiological reactions to those cues, where and those can co-occur, obviously, where you have psychological and physiological reactivity to a trigger or a cue. Sometimes you have one without the other. It'd be psychological, but not physiological. Or the really interesting ones to me are when you have that physiological reaction, where all of a sudden their heart will be racing and like, oh, I'm kind of freaking out. I don't know what's going on here. I don't feel afraid, but my body's acting like I'm afraid. That's because at some level they are reacting to that trauma, but they're they have so much avoidance, they're pushing away kind of conscious awareness of what's happening. So they have to have at least one kind of intrusion symptom, and then one or more of what I would term avoidance symptoms. This is where they're avoiding memories, thoughts, or feelings about the event, and obviously avoiding any reminders of the event, which makes sense if you're having intrusion symptoms related to triggers, that you would then avoid those triggers, avoid any reminders. Okay, 2 or more indicators of negative alterations in cognition and mood associated with the event. And this can be, in terms of like negative alterations in cognition, dissociative amnesia or other kind of lapses in memory for the traumatic event. And this is something we see a lot with victims of survivors of sexual assault, where they have a hard time describing what happened, which makes testimony obviously difficult if they ever try to prosecute those cases. But there's kind of this biological reason for that during extremely stressful times of high stress. The area of the brain involved in the stress response and the area of the brain involved in memory formation, hippocampus, same area of the brain. And so when you have high stress, it interferes with memory formation. So it's not like you knew it and now you can't remember it. It never really got from short-term to long-term memory, at least not in a kind of a complete or integrated way a lot of times for some people. So there may be some memory loss, dissociative amnesia, could be exaggerated negative beliefs about oneself, others, or the world. Often that's associated with some guilt, distorted cognitions about the event, leading to blaming. Again, that could be blaming the self, blaming others. I'm an idiot and I shouldn't have done that, and I'll never do anything right, or nobody can be trusted. The world's a dangerous place, and if the people in charge had done what they're supposed to do, this wouldn't have happened. And everybody who's in authority is an idiot, right? So that would be considered a symptom. A persistent negative emotional state, right? It could be anxious, sad. I'd say most frequently angry is probably the most common one we see with PTSD. Diminished interest in significant activities, so not wanting to go out and do things, typically things they wanted to do before. It's like, no, don't want to do that. Which again seems a bit like an avoidance symptom, right? As does this feelings of attachment from others and inability to experience positive emotions. And those used to be clustered in kind of an avoidance cluster. I'm not sure why they separated them out in DSM-5, because that the kind of emotional suppression and withdrawal from other people really in many ways does seem to be avoiding emotions, because, well, if I let myself feel emotions, even happy ones, those are too close to these other emotions that are really uncomfortable for me, and I don't want to get triggered. So just kind of pulling back in general. Okay. On to the next section. Additionally, 2 or more arousal symptoms. This can include angry outbursts, reckless or dangerous behavior, hypervigilance, where they're always kind of scanning, on alert for danger, an exaggerated startle response. It's characteristic of individuals diagnosed with PTSD, difficulties concentrating, and sleep disturbance. And that's usually difficulty falling asleep or staying asleep. Okay, so this pattern of symptoms, all these things have to occur for more than a month. Can't diagnose PTSD in that first month, typically. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, and not caused by drugs or illness, or better explained by another disorder. And then something a little bit new for DSM-5, you specify if dissociative symptoms are present. And it does seem to be the individuals that have kind of prominent dissociative symptoms, depersonalization, derealization, whether at times they feel like they're not real or the world's not real. That individuals that have those symptoms prominently seem to be different than people who aren't, and so they may end up responding to treatment differently. Still kind of investigating that, but it does seem to be a kind of different subcluster or subtype of individual. And then you can also specify if there's delayed expression. So typically the onset of symptoms is soon after the traumatic event, right? Like within a month of the event, you start having these symptoms. For delayed expression, is those individuals that don't start showing symptoms until 6 months after, which sometimes happen. Again, to some degree, it may be functional, especially think about combat-related PTSD, where somebody has a traumatic event, but they're in some sort of leadership position, or people are counting on them, and they can't afford to have symptoms, so they just kind of hold it together, suppress, ignore, and then as soon as the pressure's let off and they can stop and think, they may not have thought about the traumatic event, and then when they stop 6 months later, it may come back to them, and at that point kind of get re-traumatized by the memory, and you see the onset of the symptoms. Okay, before we go over too much more about PTSD, I wanted to touch briefly on acute stress disorder, because again, for PTSD, less than a month, you can't diagnose it, right? Because it makes sense that if something really traumatic happens to you, you should be having a lot of those symptoms for a little while. Well, how long? Well, clinically say, well, about a month. If you have them for 29 days and then are better, okay, cool, you're fine. You don't have PTSD. But if in that time frame, think about this, anybody who develops PTSD will have had those symptoms for that month. So if we just don't diagnose them during that month and they're really having these problematic symptoms, they're going to be going possibly without treatment or care because they have no diagnosis. So that's one reason acute stress disorder is there. So that's it's basically for that time period of less than a month, you can meet criteria for acute stress disorder. The idea being you've got these prominent symptoms, right? So you've had an exposure to trauma, the same definition as PTSD, and then you've got 9 or more of the PTSD symptoms related to intrusion, negative mood, dissociation, avoidance, and arousal, all the ones we talked about. So you don't have to have, one here, 2 here. It doesn't get that specific. You just have to have a bunch of them. So you've got a bunch of these PTSD symptoms. You're exposed to trauma, but it hasn't been a month yet. It's been at least 3 days. So again, it's interesting that clinicians draw these lines in the sand that, you can be dissociating and angry and avoiding people and shut yourself in your room after a traumatic event for 3 days. After that, if you're still struggling, it's psychopathology. Now label applies. But before that, it's normal. 3 days is normal. That's why 3 days? I don't know. Maybe it's biblical. But anyway, for acute stress disorder, this does allow to, again, at least give some people that may go on to develop PTSD a label so they can get treatment. And also, if you're experiencing, this level of symptomatology for more than 3 days, for a week, 2 weeks, 3 weeks, I mean, that's a significant amount of time, and that's going to cause some impairment, right? Because you think about just kind of day-to-day life. If you have a traumatic event, I need to take some time off from work, and you can probably take a week. More than a week, now your boss is going to be asking questions. You have to file more forms, right, to get extended leave. So there's some kind of societal functional reasons for that time frame, and suggesting that if the difficulty is lasting longer than that, okay, then it may be something different or unique. And of course, same kind of things in terms of clinically significant distress or impairment in functioning, and not caused by drugs, illness, or bad explained by another disorder. So again, I said everybody who meets criteria for PTSD that doesn't have delayed onset probably met criteria for acute stress disorder. But does everybody who has acute stress disorder go on to meet criteria for PTSD? Well, no, not everybody, but about half, about 50%. So there are some people that do have kind of these more extended reaction, or more than 3 days, a week, 2 weeks, 3 weeks of really significant problems dealing with a traumatic event, being in a combat situation, being raped or kidnapped or tortured, whatever it is. But then after a couple of weeks, after a month, they're probably still going to have some symptoms, but they don't have 9 symptoms anymore, or it doesn't cause enough impairment or distress to anymore be clinically significant. Okay, now it's kind of sub-threshold, and they don't go on to meet criteria for PTSD. So about half do, the other half don't. Okay, so looking at PTSD, some stats. 12-month prevalence, about 3.5% at any given point in time, with the lifetime prevalence being somewhere between 6.8 and should have been 8.5, I believe, 8.5%. Now these are kind of the official numbers for general population. If you look at veterans returning from overseas deployments, it's interesting. Some early estimates were saying, oh, it's going to be 30%. Later ones revised to 20%. And then more recent ones said, oh, no, it looks like it's only about 4 or 5%. Maybe 7% if they had confirmed combat exposure. But those, it's hard to know how accurate those numbers are, right? Veterans returning from combat have a variety of reasons to not be forthright when asked about symptoms of PTSD, right? Because everybody's asked about it now. There's screeners. They're pretty short screeners, but everybody gets a screener when they come home. And even on deployment, after certain actions, you'll get these screeners administered. So in some cases, you might think, well, individuals might be motivated to portray themselves as having more difficulties, right? Okay, well, I'm going to get out of more dangerous assignments if I say I have these symptoms. Well, let's say they don't have them, so maybe they might exaggerate. That doesn't seem to happen too much, especially among active duty. What seems to happen is the opposite, is underreporting of symptoms, right? Because of a fear that it will hamper your career. So advancement, promotion in the military may be limited if you're assigned a diagnosis of PTSD. So, the rates we're seeing are fairly low, lower than what we thought they would be. But again, possibly could it be because they're being underreported? Certainly could be, because we see these, vets from Vietnam era, and they're still at like 17-18%, higher than the more recent vets. And again, there's some cultural, societal reasons why that may be, but that's a pretty big gap. So not sure how confident we are in some of these numbers. It's interesting that PTSD seems to be much more common in the U.S. Than elsewhere. Not sure what to make of that, but it is notable. In terms of causes, now obviously the causal agent in PTSD, one piece of the puzzle is a traumatic event has to happen. You can't have PTSD without trauma. So trauma is one causal agent, but not everybody who experiences a trauma develops PTSD. In fact, it's a fairly small percentage of people that face traumatic events go on to develop post-traumatic stress. Most everybody that experiences trauma experiences some of those symptoms initially, again, the first couple of days, maybe even the first month, but those symptoms persisting after a month at a kind of a high level that's causing clinically significant distress or impairment, not that often. Well, why? What makes the difference? A couple of things. One is going to be some characteristics of, there's some intrapersonal factors, so within the person, interpersonal factors, right? Okay, treatment, therapy is wrapped up in all kinds of different bows, different kind of packages, different colors, boxes, but it's all pretty much the same thing when it comes down to it. To some degree, you're doing some imaginal exposure, right? So you're getting people to go back to the traumatic event, expose themselves to what happened. And again, typically it's imaginal. You're doing it in your mind. You're not going to make somebody, go back to Afghanistan or go back to, a place where they were sexually assaulted. Physically, that would be, offensive. But mentally, take yourself back there. Just kind of show my age. In grad school, a professor talked about, oh, you have them picture a VCR. For you young kids out there, a VCR is like a Blu-ray player or like your computer, but with tapes. And so picture this VCR, and on the tape in there is what happened. And you have the remote in your hand, and you can pause it, you can rewind, you can fast forward. All right, let's hit play. Play from the beginning. As soon as you get uncomfortable, pause and tell me you're hitting pause. And you use that kind of metaphor to walk people through playing that scene, that movie of what happened back in their mind to re-expose them to the traumatic event. right? And part of the reason you're doing that is because they need to reprocess the trauma. And what that means to reprocess the trauma depending on what kind of theoretical orientation you're talking about. For some people, it's about recreating a new narrative around the traumatic event to help it make sense in your life, and maybe recasting yourself as a character different than the one you saw before. So maybe recasting yourself from the victim character to the survivor character, but telling the story again until you can get it that way where it fits in a way that you can live your life. For some people, they say, oh no, it's about actually at this kind of cognitive biological level reprocessing the memory, again, because you have these encoding difficulties with all the high stress. So you have to go through until you get a cohesive memory that isn't full of Swiss cheese holes, right? Or you get all the pieces of the memory put together, because the idea being that you've dissociated some of the sensations from the thoughts, from the feelings, and you've got to put them all back together, right? So you're doing that, and along the way you're probably also correcting some distorted cognitions, especially that stuff about self-blame or sometimes blaming others, because people need to regain often a sense of agency that they're not helpless in the world, not at the mercy of fate, and something bad's gonna happen any day and there's nothing I can do about it. Addressing some of those possibly distorted perceptions about dangerousness of the world, or about the degree to which things may be their fault, right? If they're taking undue blame for things that's unhealthy, challenging those ideas, those cognitions, and replacing them with healthier ones. In terms of medications, there's not a medication for PTSD. They're often used in adjunct to the psychological treatment, right? Because there's a lot of anxiety and depression involved with this. So often prescribed SSRIs, selective serotonin reuptake inhibitors, which help with symptoms of depression, anxiety. So they're not treating PTSD, they're treating some of those corollary symptoms. And I guess the other thing is a little question mark: recreational drugs. So experimentally, some people are looking at drugs that have in the past been used recreationally as possible treatments for PTSD, and via very different kind of psychopharmacological pathways, right? So one would be cannabis, which primarily the thinking there is using that to address the anxiety that comes with retelling the story. So administering cannabis, so now when you reprocess the trauma, you can tell the story without the anxiety flooding your brain because you're high. Similar with ecstasy. And then kind of a different one is the use of psilocybin or mushrooms, or even sometimes LSD, hallucinogens. Very experimental stuff in terms of the treatment of PTSD. Again, trying to get people around when they really have that block where they just can't think about the trauma. Where you have this mind-altering drug that shifts your consciousness, well, maybe that's how you get around that block, that avoidance that's so strong for some people. Interesting stuff. Okay, other trauma and stress-related disorders. There's 2 attachment disorders in the DSM, and again, attachment being about those your early relationship experiences forming, leading to the development of these internal working models about self, other, in the world, right? Bowlby stuff, Mary Ainsworth stuff. So both of these being due to really child abuse. One, reactive attachment disorder. These are kids that just withdraw and won't get attached, right? So they've had some extreme insufficient care. They've been probably really neglected, or sometimes it happens with kids in the foster system. If they bounce from home to home to home and they're never anywhere long enough to attach to somebody. And okay, now they're 6 years old and we want to adopt, and they won't. They're just not gonna attach. They're not gonna get close. They're gonna have a hard time engaging in a kind of a typical social way. Even if you are putting in a year or 2 years, it will take a long time sometimes if they develop this pattern of reactive attachment disorder. So again, this idea that at some point that neurological pathway where you're getting wired to attach socially to others, which is what we seem to be designed to do for the most part, that gets messed up somehow to where now, like, nope, can't trust anybody. And again, this isn't like a 10-year-old or an adolescent or teenager who's reasoning out, I really can't trust people. This is at a very kind of primal level of something, an organism having this fundamental distrust of others. The flip side of that is this disinhibited social engagement disorder. And this is where they attach to anybody and everybody. So again, it's a reaction to extremely insufficient care. So again, it could be lots of neglect. Occasionally, this can happen with abuse as well. And these are the kids where, maybe they're in a foster home and you go visit the home and you talk to them for 5 minutes and then they're ready to go home with you. They're hanging onto your leg as soon as you walk in the door, and they will go off with anybody. So again, those attachment mechanisms, which are designed for children to attach to a primary caregiver for survival of this kind of defenseless organism, it got broken somehow, right? So for one of these, it got broken in such a way that they can't attach, and the other, they attach indiscriminately. But in both cases, kind of in response to kind of a traumatic attachment phenomenon. Adjustment disorders. So this is one of the most common things diagnosed in clinical practice because it has less of a pejorative connotation than other diagnoses, because it's kind of this temporary. By definition, it can only last so long. But a pattern of emotional and behavioral symptoms in response to a stressor or series of stressors. And you can specify if it's adjustment disorder with depressed mood, with anxiety, with mixed anxiety and depressed mood, with disturbance of conduct, or with mixed disturbance emotions and conduct. So basically, anxious, sad, acting out, or some combination of those. So something happened and you're not dealing with it. But can't be bereavement, so can't apply this criteria if it's better characterized as bereavement. And the symptoms don't persist more than 6 months past termination of the stressor. So if you're experiencing something really bad happens, this could be, let's say, you lose someone, but it's not bereavement. Could be you lost your job, or you didn't get a promotion you thought you were going to get. Something bad happened and you start feeling depressed. If you feel depressed for 4 months, okay, it's adjustment disorder with depressed mood. If it's 7 months, okay, now we can't look at adjustments anymore. This is lasting longer than it should. You should have adjusted by now. Again, we're setting these fairly arbitrary timelines on when you should, drive on. But after 6 months, okay, now we're saying it's maybe something different, more pathological, maybe major depressive disorder. Okay, the obsessive-compulsive and related disorders, OCD being the primary one here. So, for DSM diagnosis requires the presence of obsessions, compulsions, or both, right? We often think about them co-occurring. Oh, you have an obsession, in response to it, you have a compulsion. Yeah, that's typically what happens. But you could have just obsessions, and you could have just compulsions. You could have just one of them, or you could have both. It has to be at least something there. So obsession defined as a recurrent intrusive thought or image or urge that causes distress, and which the individual tries to ignore, suppress, or neutralize. And we say neutralize, that's when we're typically talking about compulsions, things you're trying to do to make that thought, that urge, that image go away, or to keep it from happening. Compulsions, repetitive behaviors, and when we say behaviors, it's kind of a loose term because counting in your head, you're not allowed. You're just thinking numbers. That's a behavior, right? That's a cognitive behavior. So a repetitive behavior, the person feels driven to perform, right? So I've got to do this to get rid of the anxiety, or I've got to do this according to these very rigid rules. And these behaviors are aimed at preventing or reducing anxiety, right? So I'm starting to feel bad. I got to do this to feel better. Feel better. Or if I don't do this, I'm going to start feeling bad. Got to do it. Or at preventing a dreaded event. If I don't check the door 3 times, I've got this feeling that my parents are going to die. Well, then I better check it. I don't want them to die. So again, obsessions, at least some obsessions present, some compulsions present, one of those or both of those. The obsessions and or compulsions are time consuming, and that means taking at least an hour a day, pretty much every day, and they cause clinically significant distress or impairment. And you really have to throw that in because some obsessive thinking, some compulsive behavior is fairly normative, especially in kind of driven type A, if you will, personality people. You see it a lot in academics and physicians, where I have to do this, I have to do this, go, go, go. Okay, yeah, you feel like you have to do it, but is this causing you clinically significant distress or impairment that you feel this way? Well, no, I'm highly successful. Okay, then it's not OCD. Quit saying you have OCD. You don't. You may have some OCD tendencies, or you may have some obsessive thoughts. You may even have some compulsive behaviors, but you don't have a disorder if it doesn't cause distress or impairment. Okay. And again, like always, not due to a drug or medical condition, or better explained by another disorder. So then you can specify the degree of insight. So good or fair insight, and this has to do with insight into how reasonable or unreasonable the obsessions and compulsions are, right? So if you have that, well, if I don't turn the knob 3 times, my parents are going to die. Yeah, I know they're not going to die, but I still feel like I have to do it. Okay, well, that's good insight. Like there's full kind of awareness that it's not rational, that it doesn't make sense. You don't have to do it, but you still feel like you have to, and you're going to feel anxious if you don't. So you don't want to feel anxious, so you still do it. Poor insight, obviously not as good. So I don't know. They probably won't die, but they might. You don't know. They might. Like I've never not done it. If I don't do it, this might be the time. And if it was, then that would be horrible. Okay, that's probably poor insight. And then when insight's absent or they're delusional, this is when you go that extreme in that they will die if I don't turn the knob. How do you not understand that? It's very simple. This is what's going to happen, where there's just no recognition that that's not consistent with physics or reality. And again, that specifies there because that may tell you about the possible course of the disorder and may influence treatment decisions. Then you should also specify if they have a current or past history of tic disorder, right? Which have a fairly high number of high level of comorbidity between OCD and tic disorder, and a tic being a repetitive vocal or motor movement, like Tourette's disorder is a type of tic disorder, verbal tic disorder. So again, you want to specify if tic disorder has ever been present, because that seems to be a cluster of individuals that may respond to particular types of medications better than others. Okay, so obsessive-compulsive disorder is not obsessive-compulsive personality disorder, and it's not perfectionism. So people say, oh, I really want it to be my way, I'm so OCD. That's not OCD. That might be obsessive-compulsive personality disorder, where you just have an incredibly rigid personality, and you might be a perfectionist, but it's not OCD. OCD is obsessions and or compulsions, right? So do you have these intrusive thoughts? If you just have, well, I like things to be a certain way, okay, that's a preference. If they're not that way, do you have a thought coming in your head saying, this is wrong, this is bad, fix it, it's bad, something bad's going to happen? Okay, well, if that happens, yeah, then that's more consistent with obsessive-compulsive disorder. Overall, fairly rare disorder compared to some of the other anxiety disorders. Well, that's weird. 12-month prevalence rate around 1%, with lifetime prevalence rate being only 1.6 to 2.3%. Whereas we've seen some other anxiety disorders, right, there are 3, 4, as high as 10% for lifetime prevalence. So this one's a little more rare. Another thing that's interesting about it would suggest maybe some more biological inputs and less social cultural ones. We see a fairly equivalent gender ratio here, whereas a lot of the other ones we see more women than men, which is probably has to do with gender roles and culture and all that stuff. Well, that doesn't seem to have an effect on OCD. You have roughly equal numbers of men and women, but you do have this difference in typical onset, where men are more likely to first experience symptoms as boys, younger, and women more likely to experience it as adolescents, early adults. But for men or women, you're going to have onset typically by early adulthood. It's pretty rare to see OCD first emerge after 35. In terms of causes, obviously psychological, biological vulnerabilities. For psychological, one thing that's thought to play a role here is at some point these individuals learn that thoughts are dangerous, right? Oh, you shouldn't think that. And that is probably coming from parents or family or something close culturally, with that idea getting in their head that, okay, if you think this, that's bad, or this thought is equivalent to the action. If you think it, you might as well have done it. Okay, that kind of thinking seems to be more common in people with OCD. And then, of course, there seems to be a general biological vulnerability. So there's not high heritability for OCD, but if somebody in your family has an anxiety disorder, that increases the risk of OCD. And if someone in the family has OCD, it increases the risk of an anxiety disorder for the descendants. In terms of treatment, pretty effective using exposure and response prevention. I'm not sure why your book calls it exposure and ritual prevention. I haven't seen that before. But this is where, again, typically they're going to have obsession followed by compulsion, right? They have a thought, causes anxiety, and now I have to do the compulsion to make the anxiety go away. Exposure with response prevention is exposing them to the thought or anything that triggers the thought, and then prevent the inaction of the compulsive ritual. So, okay, you're going to go touch that doorknob, and when you do, you're going to have that thought, oh, there's germs all over here, and I'm going to get hepatitis. And then you would typically compulsively wash your hand for 2 hours. So the therapy is you have them touch the doorknob and then sit in your office with their hands in their lap. Right? But again, you're not sitting there. You're talking about it. You're talking about how they're feeling, and you've given them some skills in terms of progressive muscle relaxation, guided imagery, deep breathing. You're anxious, but remember, this feeling will pass. You're aware that hepatitis isn't passed from doorknob to hand. You know that it can only live on non-organic substances for, I don't know, however long hepatitis can live. So you're feeding them facts and helping them, giving them skills to cope with the anxiety. And eventually, the anxiety goes away. And if the anxiety can go away, then that starts to break that connection, that stimulus-response connection between obsessions and compulsions. In terms of medications, clomipramine is the most commonly used one. This book is a little misleading. It tells you, oh, it's drugs that target serotonin. Well, not really, because there's a lot of SSRIs, selective serotonin reuptake inhibitors, that don't do very well in treating OCD. The drug that seems to do the best is this clomipramine, which is an older one. It's a TCA, tricyclic antidepressant. And it does inhibit the reuptake of serotonin, but it's not an SSRI, it's an SNRI, because it also inhibits the reuptake of norepinephrine. So it's the S and the N are serotonin, norepinephrine. Reuptake R and I are reuptake inhibitors. So that means that whenever there's these pathways in the brain that seem to be involved in OCD thinking, and those pathways are probably, some of them are serotonergic and noradrenergic pathways. So they're releasing serotonin, releasing norepinephrine across the synapse. And if you give people this drug, clomipramine, what it does is when those neurotransmitters are released, right, they go across and they make the next cell fire. Okay, so typically that happens, and then the presynaptic cell sucks the stuff back up via a process called reuptake. The reuptake inhibitors blocks that, so when serotonin and norepinephrine goes out, hits the next cell, makes it fire, tries to go back, can't go back, well shit, might as well do this again, floats back across, makes the cell fire again. Okay, so it's increasing the activity of serotonin and norepinephrine. So it's not more of those neurotransmitters, but it's getting more out of them. Now, the interesting thing is, with any type of reuptake inhibitor, it's not real clear what the action is. because you think, oh, well, she's making it fire more. So the more of that firing must be good. So people with OCD must have underactive parts of their brain. Maybe, because one thing that happens with these drugs, reuptake inhibitors, is they typically cause more firing initially, but they also often lead to changes in sensitivity of those postsynaptic neurons and downregulation. So you may lead to actually less serotonergic or noradrenergic activity rather than more over time. And maybe that's the thing that's therapeutic. Maybe. Depends on which circuit we're talking about, which part of the brain, and what other things are having inputs there. So that drug seems to be fairly effective, but still not sure why. But it's certainly not as simple as, oh, it's serotonin. You need more serotonin. It's not that simple. Okay, another disorder that's been moved into this category of kind of obsessive compulsive related disorders is body dysmorphic disorder. Right? It used to be with eating disorders because it often co-occurs with eating disorders. It involves a preoccupation with one or more perceived flaws in physical appearance, and this is a flaw that isn't apparent to anybody else. This isn't like somebody that has, a huge scar across the face, like, oh, the scar is so ugly. No, it's somebody that has, a dimple and says, oh, look at this crater in my face. You mean that dimple? Yeah, isn't it horrible? Or they think it's grotesque, and they're preoccupied with it. They think about it more than is typical, right? So a lot of people have, oh, this thing's kind of weird about me. I don't really like this part of my face, my body, whatever. Yeah, that happens. And it often peaks in early adulthood, in college, this kind of preoccupation with physical appearance, which makes sense in kind of the societal thing of mate attraction and whatnot. But for individuals with BDD, body dysmorphic disorder, it's a preoccupation. That's all they can think about. And it gets in the way of thinking about other things. And at some point in the course of disorder, they've had some repetitive behaviors in response to the concern, like mirror checking or covering up repeatedly, with their hand or something, some part of their face over and over again, because they don't want people to see this hideous grotesqueness that, again, nobody else can see. Okay, so this preoccupation causes clinically significant distress or impairment, and of course, it's not due to. Okay, so. Prevalence rates probably higher than the estimates we have. 12-month prevalence rate, maybe 2.4%. We say it's probably higher because these folks aren't going to present to clinics, and they don't think they have a psychological disorder. They think they have a physical defect. Oh, my ears are huge. You don't understand. This is why I'm going to the doctor. So the prevalence rate may be much higher than that, but that's kind of a guess. Interestingly, there are some data that so where these folks go are typically physicians, so dermatologists, plastic surgeons. Dermatologists, that's weird. My wife's dermatologist. Yeah, because they come in and think they have these blemishes on their skin, that there's nothing there, but they think there's something there. So it's not always kind of my nose is too big, my ears are too big, my mouth is shaped weird. It can just be a spot or spots that you see that nobody else sees, or discolorations. But there are reports that in dermatology clinics, 9 to 15% of the patients presenting there may have body dysmorphic disorder, and similar rates presenting to plastic surgery. Those of you who are sexist may think, oh, this sounds like a woman thing. Women are so vain, right? Because that's our stereotype. But no, men are just as vain. Similar rates in men and women, but they tend to focus on different things. Men's focus tends to be fairly restrictive in terms of hair loss, genitals, and muscular development. They seem to be less concerned. Typically, there are exceptions always about amount of fat, or my arms are to this, my legs are to that, my hips are to this, different body parts. Whereas women have a greater diversity of concerns that they present with. So some general differences in presentation, but similar rates. And overall, the most common presenting concerns are related to concerns around the face, because again, that's what most people can see. The causes, it's a bit of a mystery. probably similar to OCD in terms of general biological and psychological vulnerability. And we say that largely because a lot of the treatments that we'll talk about here in a minute that are effective for OCD are the same things you end up using for body dysmorphic disorder. So if the same treatment works, well, maybe it's caused by the same process somewhere along the line. Maybe. So exposure-based therapies, having them sit and look at the hideous thing they're trying to hide all the time, and use kind of self-reaffirming statements and ask other people, hey, do you see this thing? And if people repeat saying, no, I don't. Exposing them to the thing that they're afraid of, because they're going to try to hide it, right? So you don't let them hide it anymore. If they don't hide it and that doesn't kill them, they aren't overwhelmed with anxiety, and the anxiety decreases. SSRIs, selective serotonin reuptake inhibitors, some success. But again, most of these folks don't seek intervention for the disorder. They seek medical interventions, a lot of plastic surgery. And so you'll think, oh, well, yeah, this is a plastic surgeon's dream, somebody that, because they're going to keep coming back. No, this is a plastic surgeon's nightmare, because they are never going to be satisfied with the outcome of your procedure. And so you've got a fairly high risk for a malpractice lawsuit from these individuals, because they're going to come back. And if you do all the surgeries, eventually you probably will be committing malpractice. So physicians should probably work with psychologists to better screen these individuals to make sure that they get the appropriate care they need and don't get unnecessary medical procedures. Okay, other obsessive-compulsive related disorders. Hoarding disorder. It's one that people are much more familiar with more recently after the A&E show, Hoarders, right? This is just difficulty discarding items. It's interesting, though, well, to me anyway, because one of the criteria specifically in DSM is that you have to keep this stuff that's really not really valuable, but also keeping the stuff leads to accumulation that gets in the way of living. Now, that's interesting, because that means that two people, let's say two identical twins, clones who are raised in identical environments, and they both develop this kind of hoarding behavior. But one of them wins the lottery, and the other one lives in a one-bedroom apartment. They're both keeping stuff. The one who lives in the one-bedroom apartment is probably going to meet criteria for hoarding disorder much sooner, because they're going to fill up that one-bedroom apartment. The one who won the lottery, obviously they can buy more stuff, but they could also buy a huge house, and they could buy warehouses to keep all their stuff. And so it'll probably take them much longer to meet criteria. They may never meet criteria, right? So because they have more resources, they're less likely to be diagnosed with disorder, even if they're actually exhibiting the same behaviors. And that's just a little weird to me. And then there are two, what we refer to as habit disorders in this group as well. One being trichotillomania, and this is recurrent hair pulling. And it's a kind of it's interesting that it's in here with OCD, because it can co-occur, not super frequently, but it doesn't seem to be the same in terms of people that are pulling their hair. It's not like they have this compulsion like, oh, I have to pull my hair, I don't want to, and then they do it. No, it's more of a mindless habit where, and we often see it in kids, where they're sitting watching TV, playing video games, kind of zoning out, focusing on whatever they're doing, and then with one hand, not even noticing, boink, boink, pulling out hairs. Right? And occasionally they will eat the hairs, right? In which case you have to look out for forming a bezoar, right? Forming a hairball in their stomach. And again, they often, interestingly, present to dermatology because they have alopecia, right? Hair loss. Like, I don't know, they've got this bald spot, and then eventually figure out, oh, that's because they're not going bald. They've been pulling their hair out, and you find it, under the mattress, or do an ultrasound, find a hairball in their stomach. But again, kind of I can see how it's in the group with OCD, right? Because it is this kind of compulsive behavior, but it's not a mindful compulsion. It's more of a mindless compulsion. That is very much a habit. Where this is kind of what I do. Oh, this is the thing that I've gotten in a pattern of doing, and it's hard to break up these patterns. Hard to break a habit. Another habit that's new to the DSM would be excoriation. Very similar. It's just recurrent skin picking. And again, For both of these things, they have to cause clinically significant distress or impairment. Because a lot of people, maybe, oh, that's a weird looking hair. I'm going to pull it. That feels better. Okay, that happens. But if you do it enough, right, it's about severity, it's trichotillomania. Same with excoriation. A lot of people I know pick at scabs. Quit picking that scab. Oh, sorry. But if you do it to the point that you're causing scarring, okay, now we're looking at a possible disorder level. So it's all a matter of degree. Good news for these things, pretty effective treatments in terms of habit reversal training, very behaviorally oriented treatment to increase mindfulness of what you're doing and break those habitual patterns. Pretty good success rates with that. Okay, take home for all this. For the trauma and stress-related disorders. Again, it seems to be this extended fallout from negative events. PTSD, these attachment disorders. Something bad happens early in life, later in life. You have a negative reaction, and that negative reaction is kind of normative for a particular time frame. But if you keep having this negative reaction past what's kind of culturally, socially normative, well, now it's pathological, and it gets labeled. And again, that may be because there's some initial difficulty processing the trauma, right? In terms of getting those memories encoded well, and then subsequent to the trauma, there's this drive to avoid trauma-related stimuli. So you don't tell the story, you don't think about it, and the more you run away from that traumatic event, from that memory, the longer it seems to stay in the background, causing problems, because you're trying to use part of your mind, your brain, to keep this one plate spinning. Can't think about that, can't think about that. Well, you've got finite cognitive resources, right? And if you're always dedicating some cognitive resources to avoiding that, other plates are falling, right? Things that need to be done can't be done, and your cognitive emotional energy is kind of tied up. For obsessive-compulsive disorders, I think one way to think about this is it's kind of like a computer gets a virus, this kind of glitch in a program, and you keep having these pop-ups. These pop-ups are causing anxiety. But what's interesting is that kind of the fix isn't to get rid of the virus. It's to say, oh yeah, pop-ups, those will go away eventually, to not worry about it. So I'm not sure how well that metaphor fits. Big picture for these disorders, the obsessive-compulsive disorders, the trauma, stress-related disorders, and also going back to the anxiety disorders we talked about previously in terms of treatments. For all these things, it's almost always, to some degree, about exposure. Exposure to a thing that's causing you anxiety, right? When we have pathological stress and anxiety reactions across time, typically it's because we're avoiding the thing that scares us, the thing that makes us anxious. For PTSD, it's avoiding the memory of the trauma. For OCD, it's avoiding these unwanted thoughts, right? Because if you can have the thoughts, oh yeah, there's that thought again, less likely to be a problem. But if you are pushing away, you're scared of it, you run from it, that causes problems. With phobias, again, here's this specific phobia, it's got to run from that. Every time I run from that, I'm reinforcing the avoidance, and I'm leaving that initial connection intact. And then generalized anxiety disorder, again, you're worrying about everything, but you're not allowing yourself to feel the kind of emotional aspects of anxiety and the kind of the imagery associated with anxiety. It's just focusing on the thought part, and focusing on the thought part so much because the rest of the fear scares the crap out of you. But if I just worry, if I think, well, then I won't have to face the other part that I'm afraid of. So the anxiety disorders are largely about avoidance. And so a lot of the treatment is about stop avoiding. Expose yourself to the thing you're scared of, and eventually it won't scare you anymore. So good news is most of these things we've got some pretty good treatments for. Not every disorder, not every difficulty, but the anxiety disorders, trauma disorders, obsessive-compulsive disorders, psychosocial interventions, sometimes with the help of medication and medical interventions, the prognosis is good. Okay. That's all for now. Take care.